the cranial end and the caudal end of the embryo. In the context of this talk, I'm going to focus on 3 different groups. Those that I would describe as catastrophic anomalies affecting the cranial end particularly, such as anencephaly, but also I'm going to include idiencephaly. And I separate these because they are relatively easy to identify at 12 weeks of gestation, provided you know the signs to look for. Then you have diagnoses such as an encephalocele, typically occipital encephalocele, and here the issue at 12 weeks is there are cases that have been reported where the defect is visible, but then perhaps a week later is not as obvious, and then becomes more apparent again later in the pregnancy. So this tells us that sometimes pathologies at 12 weeks are not absolutely set, and there will be continued development of pathology with advancing gestation. And then the third group I wanted to talk about are screening for open spina bifida, and this is a little bit more challenging at 12 weeks, and I wanted to really set the scene for what we can do at 12 weeks, but I think Simon's also going to talk a little bit about the imaging at that gestation. So, from my perspective, the biggest issue that we have with neural tube defects is that they are identified, they develop so early in gestation. So this is happening about the 3rd week after conception. And this means that our ability to treat this is always going to be limited because of the fact that the defect is so entrenched in embryology and embryonic development. Fundamentally, if we want to stop neural tube defects, we have to recognize that there are dietary deficiencies that are associated with this type of anomaly. And that means that actually one of our major focuses should be on folic acid supplementation for women of reproductive age. Interestingly, on the right-hand side of this slide, there are relatively few studies which formally demonstrate the value of supplementation with folic acid. But the data are there, and there are some randomized controlled trials, particularly for fortification in high-risk groups. I finished, apparently. Okay, so from the research I did, I understand that the Vietnamese government do follow the policies of things like the World Health Organization in terms of recommending folic acid fortification for women in pregnancy. But I also understand that folic acid has to be prescribed by a physician. And I think that that potentially gives us a missed opportunity. Because remember, the defect is identified or is developing at 3 weeks of gestation. And we don't see pregnant women as obstetricians at that gestation. So it's important that we make sure that we identify in the community that preconceptual fortification is necessary, and that women should be taking this for at least 12 weeks before they plan to start a pregnancy. The alternative approach is to fortify foods like flour with folic acid, and this is something that has happened actually relatively recently in Australia. I think it was 2009 that the federal government instituted the policy of fortification of flour. And when I was preparing for this talk, I just wanted to know what the situation was in Vietnam, and I found this in the Saigon News written about the issues of folic acid supplementation. So, moving on. If we come to the first trimester scan wanting to identify fetal abnormalities, some of the commonest anomalies that we're going to see are going to be related to the central nervous system. And if we then dial down into the CNS anomalies, you can see that the commonest amongst those are actually acrania, which is the 40% group, and then you have holoprosencephaly and spina bifida. So in fact, if we were to focus on trying to detect these anomalies in the first trimester, we would have a very significant impact, I think, on the overall rate of CNS anomalies for children born at the end of pregnancy. As I said earlier, acrania is relatively easy to recognise in the first trimester. If you look at the bottom image on the left-hand side, here you can see a normal biparietal diameter head circumference, and you can see the calcification of the skull. And that identifies a normal cranium for the fetus. If that is absent, and then if you have views perhaps like the one on the right-hand side, where you cannot see the cranium, and now you can see brain tissue essentially in contact with amniotic fluid, then this is a feature of acrania in the first trimester. And simply by making sure that we measure the head circumference and the biparietal diameter on every first trimester scan, we have a means of identifying when those measurements are not possible, and therefore of making this diagnosis essentially 100% of the time. If you take the encephalocele, then as I said before, these can vary. So for example, on the right-hand side, there's an example here where there's not yet brain tissue in this lesion. In fact, if we continue like this and the brain looks normal for the remainder of pregnancy, this potentially is a relatively easy surgical repair. But the difficulty that we have with encephalocele in the first trimester is we do see the contents of an encephalocele vary quite markedly between about 12 and 24 weeks. So let's focus on spina bifida and the story of screening for mural tube defects, because I think the history is quite interesting. So we'll start by perhaps looking at the diagnostic process, which used to use amniocentesis. We'll then look at how we screen using alpha-fetoprotein, and then look at how we move to ultrasound. And that predominantly was then at 20 weeks and then moves to 12 weeks of gestation. So this is some data from a study published a long time ago now, 1983, which looked at using amniocentesis to look for alpha-fetoprotein. And if the alpha-fetoprotein was above the 97th percentile, then that was identified as placing you at extremely high risk of spina bifida. Almost diagnostic in the context that the specificity of the test was 99%, and the sensitivity you can see is also very, very high at 97% level. So this is, I think, the first test that we have developed where we had a degree of certainty about the diagnosis that therefore potentially enabled some intervention in pregnancy. Now, we've moved on from there, so the first question actually is, well, who should have that amniocentesis to check for spina bifida? Do you do that for the whole population, or do you do that for high-risk groups? So if you're going to select a high-risk group, you could do that purely by using maternal age. And you can see here different risk factors that you have on the basis of, maternal history. And so you can see, for example, if you've had a previous pregnancy affected by spina bifida, then you have perhaps a 20-fold increased risk in the current pregnancy. So just to put that in some perspective, if you are in the UK and overall prevalence of disease of 1 in 1,000 pregnancies, and your first pregnancy is affected by a neural tube defect, then your second pregnancy now has a risk of the order of 1 in 50 instead of 1 in 1,000. And you can see there's also chronic medical conditions associated with spina bifida and various other treatments and genetic anomalies. The problem with history is that if you use that as a means of identifying a high-risk group, you'll probably only pick up 10% of spina bifida. So we need to move beyond that, and traditionally in screening, the route forwards was in the second trimester, because most women were presenting between 16 and 20 weeks of pregnancy, and we would do second trimester biochemistry. And using techniques like electrophoresis, people soon recognized that pregnancies that had neural tube defects actually had raised protein levels of something called alpha-fetoprotein. And once you've identified this marker, you can then recognize that actually quantification of alpha-fetoprotein is also useful in identifying a high-risk group. So on the right-hand side, you can see on the left of the three curves, the normal range of AFP in a population. And here it's expressed as what we call multiple of the median, which allows you to correct for gestational age. I'll come back to that in a moment. Correct for maternal weight. And you can see that the normogram for an unaffected population is distributed around 1 multiple of the median. Then you have 2 abnormal cohorts. You have fetuses with an open spina bifida and fetuses with an anencephaly. And you can see the right shift that you get in those populations. Now, you can imagine if you do an AFP test and the reported value is 10 multiples of the median, you're quite clearly now in the distribution of one of the abnormal groups. And you're outside of the distribution of the normal group. So that's almost diagnostic at that point. But obviously, as you come back to lower levels of AFP, you can see there's the potential that you're either a true or a false positive, and that's why this is a screening tool, it's not a diagnostic tool. It's important to recognise that you can have false positive results. So on the left, you can see a whole range of anomalies that are potentially associated with a raised AFP. So once you begin to recognise the limitations of AFP screening, you need to do 2 things. The first is you need to do an ultrasound scan to date the pregnancy, because that's how you present moms rather than raw data. And the second is that you need to do an ultrasound scan to make sure that you don't have one of the other major anomalies that could be associated with a raised AFP. And so once you start doing ultrasound, you then begin to recognise that actually ultrasound is a better screening tool than the AFP test itself. So once we start to date pregnancies by using the traditional views where we can look at the biparietal diameter and the head circumference, and once we start to examine the shape of the head and look at other structures in the head, looking at the posterior fossa, we begin to recognise that there are a series of anomalies that are specifically associated with spina bifida. So, remember family history, 10% effective. Screening with AFP, perhaps about 50% effective. If I just look at babies that have a small biparietal diameter, less than the 5th centile, 60% sensitivity of screening. If I then add other features like ventriculomegaly and looking at the changes in the cerebellum and looking at the changes in the shape of the skull, you can see the sensitivity of this tool is becoming diagnostic. And this is just an example of a case that we saw recently. So you can see you've got the scalloping of the parietal bones, giving you the lemon shape that we talk about. Down the bottom, the abnormal cerebellum with the banana shape rather than the traditional figure of 8 shape. Here, if you look at the spine, you can clearly see the spina bifida lesion itself. and you can obviously do that in 3 different planes. So mid-sagittal, coronal, and axial. So where are we at by the end of the 1980s? Well, the process of screening is evolving. We're moving away from maternal history alone. We've gone through a period where we used maternal serum AFP. We recognise that AFP worked best when we do an ultrasound scan, and now we've found that actually the ultrasound scan has the best markers for spina bifida. And so, if you look at population-based screening across Europe, the minimum detection rates using ultrasound at 20 weeks was about 80%, ranging up to 95% of cases. Interestingly, at this stage, there was also a publication about screening in the first trimester rather than at 20 weeks gestation, and instead of an 80 to 90% sensitivity, the authors reported a 13-14% sensitivity. So at this stage, we didn't have the tools to move this to 12 weeks. So the questions that parents want to ask are slightly different to just pure diagnosis. They want to know how this lesion will impact their child. Will my baby survive? Will it have brain damage? Will my child be able to walk? Will my child be continent? And also, are there any other problems I need to know? So again, from an imaging perspective, I think there are signs here that we can use to help our discussion. If you see significant ventriculomegaly, it's more likely this baby is going to need an interventricular shunt. In most circumstances, that's a process that actually goes very well, it's quite straightforward, but occasionally you'll get infections associated with shunts, bleeding associated with shunts. You'll have neurodevelopmental impacts of that. You can look at the shape of the cerebellum, and then you can look at the spinal lesion itself, and you can define the site of the lesion, and you can define the levels that are affected, and then you can look at things like talipes to help you define abnormalities that are going to have prognostic implications. And there are papers that have described these in different outcomes, looking at these different signs. In fact, we're not very good with ultrasound at defining the precise level of the lesion. So, let's remember in 2026 we can use other technologies. We can use MRI to help us define the level of the lesion and to look also for other impacts on the CNS. These are just some examples here. And then obviously here sometimes you can see other features here, for example, of the brain injury that this child has as a secondary effect. And what we're trying to do potentially prenatally is identify a group that might be amenable to some fetal surgical intervention. The MOMS trial that was done in the United States before 2000 cost $25 million. And I question whether, for most of our communities, this is the most necessary intervention we need to plan in medicine, in obstetric care, at this point in time. But there are centres that offer this around the world, and I think that there needs to be some discussion in any community about whether we feel this is something we want to provide locally or whether we use resources of others. First trimester. Going back to 2013, we began to see use of additional markers in the first trimester, BPD, AFP, lifting the detection rate to about 60%. Then we see the description of the additional markers, so we're talking about the ultrasound markers, looking at things like the intracranial translucency, the space of the fourth ventricle, and looking at the brain ratios of the brainstem to the occipital bone. And there are a number of publications that suggest that this is a really strong marker of looking for things like spina bifida. The original publication had a 100% detection rate. We also know that if the brain, the BSOB, moves the other way, it's associated with other problems of the posterior fossa. And so now, if we're doing a complete first trimester scan, we should include normal views of the anatomy of the posterior fossa, and these include axial views of the brain that allow us to look at the posterior fossa as well. And that very readily allows us to pick up spina bifida in the first trimester. There are now screening studies that are picking up 80% at this gestation. It's important then to recognise that this could be either an isolated anomaly, or it could be associated with other structural abnormalities, so we need to search for those, and with chromosomal abnormalities. So this baby actually had trisomy 18. And here you see another abnormality of the posterior fossa, so you can see the increased space there posteriorly, and this fetus actually has triploid. 2 more slides. The first is there is a comparison of the ultrasound markers at 12 and 20 weeks. We are using different markers at these 2 gestational ages. The second is that the story might not stop here. So this is an example of a Chinese study that looked at a series of microRNAs, so things that you could look at the same time as doing your NIPT test that will predict spina bifida and anencephaly. This study was actually done at 9 weeks gestation. And finally, within the ultrasound community, we might see improved quality assurance and therefore increased sensitivity of screening and better equity across populations by using various AI techniques to look at the posterior fossa in the first trimester. So I will stop there, but I will just say that if you ask me what the most important thing is that we do as a community to prevent neural tube defects, it's to make sure that we prescribe folic acid to women